My third video, and over here, sorry, my fourth. Yeah, my fourth video, and here I will be talking about the beta blockers, and I will first be discussing the first generation beta blockers or the non-selective beta blockers. Now let's quickly learn their names. The most famous of them all, propanolol. The most ignored, oxpranolol, pindolol, penbutalol, around about there. Then there is timolol and nadolol. I'll just mention a few pharmacokinetic properties over here. Propanolol has the minimum oral bioavailability, BA for short. Okay, minimum oral bioavailability approximately 30%. Oxpranolol and not oxpranolol, pindolol and penbutalol. These have the max oral bioavailability, nearly 100%. And remember, this is among all beta blockers, all generations of the beta blockers. Okay. Nadolol is the longest acting, again amongst all beta blockers. Timolol is used as a topical beta blocker in case of hemangiomas. And it has high water solubility. Also, you should remember that propanolol and penbutalol have high lipid solubility. Okay, some important pharmacokinetic properties. Let's now move on to some of their important contraindications. Okay, most important contraindication is chronic obstructive pulmonary disease and bronchial asthma. Why? I hope you recall from my receptors portion, beta 2 receptor is responsible for bronchodilation, and hence in a patient of bronchial asthma, if you give a non-selective beta blocker which blocks beta 2, you can imagine the effects. In fact, I would just like to mention that all the undesirable effects and all the contraindications are due to the fact that these drugs are blocking beta 2 receptors in addition to the beta 1 receptors. All our pharmacologically important actions are due to beta 1 blockade, but the side effects and contraindications are due to beta 2 blockade. Now, one important drug interactions we are all asked in our exams is propanolol and insulin. Now what happens? A diabetic patient, what he or she does is that he or she may decrease his or her food intake or may increase his or her dose of insulin intake. Or sometimes there might be a combination of both, because he or she would like to control his or her blood sugar a little better, and so he or she will do these two things. Often it's a combination of both, and as a result the patient will develop hypoglycemia. It's a life-threatening condition. Now, here comes the important part. We know that beta 2 receptors control gluconeogenesis and glycogenolysis in the liver. And that's why it was so important to learn about the location and the functions of the receptors below. Now you can easily tell me what will happen if we give a non-selective beta blocker in a diabetic patient taking insulin. Due to this, there will be further potentiation of hypoglycemia. There will be masking of the symptoms of hypoglycemia. And there will be one more thing which you don't know, which I haven't discussed yet, is that due to sympathetic blockade, most of the symptoms of hypoglycemia will disappear. Masking of the effects of hypoglycemia. Now, what are the effects of hypoglycemia? Hypoglycemia effects are anxiety, palpitation, tremors, dizziness, and sweating. These are the mechanisms by which the body alerts the person that look, you're going into hypoglycemia. Now, if we give a non-selective beta blocker due to sympathetic blockade, these effects will completely disappear. Only sweating will be present. And why is that? Sweating will be present because it is mediated by sympathetic cholinergic fibers. Yes, is mediated by sympathetic cholinergic fibers, and hence this effect will always be present. However, sweating, as you know, sweating can occur in a variety of conditions, and hence the patient will not be able to recognize it that it is occurring due to hypoglycemia. If these had been present, the patient would at least have known that there is something wrong with my body. However, and in the most of the diabetic patients are educated and alerted to the facts that these are the symptoms of hypoglycemia. If at any condition these arise, the steps which they should take immediately are also told to them. Now, due to beta 2 blockade, there might also be insulin resistance. This is not related to the drug interaction of propanolol and insulin. This is a different effect. Due to beta 2 blockade, there will no longer be vasodilatation, because I told you that beta 2 receptors also control vasodilatation, and I've already discussed the effects in the liver, the gluconeogenesis and glycogenolysis. These will be absent, and hence the patient's exercising ability will be decreased. Okay, now a bit about beta blocker toxicity. We know that all the three beta receptors are GS type, and hence if we block beta receptors, there being decreased intracellular cyclic AMP levels. The patient may also develop AV block, and the patient may also have hypotension. The drug of choice in case of decreased cyclic AMP is glucagon. In case of AV block, we give atropine. And in case of hypotension, we give isoproterenol. Now you might get confused as to why this hypotension is developing when I've already discussed that beta 2 receptors control vasodilatation. This is due to the effect of the beta 1 receptor, and that is why beta blockers are given in hypertension. Beta 1 receptors are present on the JG cells, mediate renin release, which activate the RAS axis, which leads to sodium water retention, the salt water retention. This leads to hypertension. If beta blockers are given, this entire pathway is blocked, and in case of overdose, the patient may develop hypertension. Now, the uses of the non-selective beta blockers in general are limited, but propanolol has a wide range of uses. Okay. Propanolol is the drug of choice for prophylaxis of migraine and essential tremors. Propanolol may also be given in case of hyperthyroidism, in case of in hypertension, the cardioselective, as a second generation beta blockers, are more preferred, and in two conditions, that is HOCM and aortic dissection, they may be given. Now, why is that? What happens in HOCM is that due to hypertrophy of the cardiac muscles, when they contract, the left outflow tract becomes so narrow that it is blocked, and hence blood cannot pass. So when we give beta blockers, there is decreased force of contraction due to beta 1 blockade, and hence this will lead to decreased obstruction. In case of dissection, blood will flow in aortic dissection. Blood will flow in between the layers of the aorta. Okay. Suppose these are the layers of the aorta, and blood will flow in between them. You will learn about in pathology. In fact, you will also learn about of HOCM. In aortic dissection, there is also a DeBakey classification 1, 2, 3. You will learn. In aortic dissection, if we give beta blockers, there will be decreased risk of development of aneurysm and decreased risk of rupture. Yeah, and beta blockers, mainly I'm talking about propanolol over here. Propanolol may also be given in case of anxiety. It may also be given in case of variceal bleeding prophylaxis. in portal hypertension. Yes, you remember from anatomy that in case of portal hypertension, the esophageal veins will dilate and they might rupture and lead to bleeds. And in case of prophylaxis, we may give propanolol. And I've talked about the migraine, and I've also talked about the fact that topical timolol, may be given in case of hemangiomas. So yeah, that's it for the non-selective beta blockers. The most important drug is of course propanolol. You should remember all its uses. You should remember about the drug interaction, the contraindications, the uses, and some of these pharmacokinetic properties. If you can remember, it's well and good. Yeah, that's all.